Hello, this is Maher Abbas from Dubai, and it's an honor and a privilege to present at your conference. I would like to thank the Scientific Program Committee for the kind invitation. Today, I'm tasked to speak about the workup in the medical management of fecal incontinence. I have three objectives for this talk. I'd like to provide you with a brief overview of fecal incontinence and the causes of this condition, to share with you how I evaluate the patient, and finally, I will discuss some of the current medical management we have. The surgical management and surgical options for fecal incontinence will not be discussed in this talk. Now, I would like to refer you to this comprehensive article in the current management of fecal incontinence. This was published in 2013 in the Permanente Journal from the US. You do have free access to this article, and it will give you a broad foundation to the management of fecal incontinence, granted that some of the surgical options listed in this article have evolved since its original publication. Fecal incontinence is basically the involuntary loss of stool control, the inability to hold or defer a bowel motion until the appropriate setting to reach a bathroom. There has been many studies that have looked at the worldwide prevalence of this condition, and it had been reported anywhere from 1.4% to nearly 13%. Probably most recent studies will report approximately 10 to 12% prevalence in any given country. Fecal incontinence has a negative impact on quality of life. It can lead to social isolation in many patients. In young working patients, they can have difficulty with their job. And those who are in relationship may be abandoned by their partner. It can lead to divorces. And in elderly patient, the biggest fear of incontinent patient is ending up in a nursing home. It also leads to significant amount of behavioral modification. This is quote unquote from one of my patients: no matter where I am, I need to know where all the bathrooms are. So socially, when this patient is active, they always need to map out in their mind where a bathroom so that they can reach it immediately should they feel the urge to go. It can lead to significant mental illness with depression, fear, and paranoia. Being the most common, can also lead to shame, and approximately 1/3 of the patient have discussed the issue with the physician. The majority do not. They're ashamed and they're fearful of bringing up the topic. Now, I often get asked, is it worse for the young patient or the elderly patient? I would venture to say it's miserable for both. For a young patient, it can interfere with work, marriage, and sexual activity, and for older patient, it can interfere with enjoying retirement. However, what is different is the expectation of the treatment. For the young patient, they need a very good result in order to carry on the work-related activities and be active within their marriages. For elderly patient, they have enough expectation to get better to the point where they can function a little bit better socially and to avoid a nursing home or a diverting stoma. It's important to note that continence is a complex mechanism that involves both the digestive tract as well as the anorectal and pelvic floor function. From a digestive tract, intestinal motility is very important. The frequency, volume, and consistency of the stool. For instance, you may take a patient with a moderate function of the anus, but they have very bad diarrhea, and these patients will be incontinent. And you can take patients who have a poor function of the anal area, but they have consistent regular stool that is well formed, and they may not witness much incontinence symptom. The pelvic floor contributes significantly to the continence mechanism, sensation, compliance of the rectum. The internal sphincter muscle is very important, contribute to the vast majority of the resting tone, and the external sphincter muscle, as well as the puborectalis and levator ani, will provide the squeeze pressure. And in some patients, especially elderly women, the hemorrhoid, especially if they're large hemorrhoid, may provide some extra sensation and a cushion to minimize the degree of incontinence. Brief review of the anatomy of the anorectal junction. The rectum basically tapers off down in the pelvic floor or through the pelvic floor to become the internal sphincter muscle, denoted here in the light brown color. And the levator ani is the red color here. It terminates into the external sphincter muscle, which has three components: the deep, superficial, and subcutaneous portion. So both the internal sphincter muscle and the external sphincter muscle are important. In terms of etiologies, the most common etiology globally is a sphincter injury. By far, these are related to childbirth. We do have some patients who have undergone prior anorectal or urologic procedure. Some patients may have blunt or penetrating trauma that can lead to incontinence. Rarely, incontinence can be related to a neoplastic process with a malignancy involving the pelvis or a functional benign disorder such as rectal prolapse. Obstetrical injury is not something new. We've had vaginal delivery since the beginning of humankind, and the extent of the injury can determine whether a patient has severe incontinence or not. There are 4 degrees of perineal tear as described here. An easy way to remember is the cheeseburger model. The cheeseburger model, basically you have 2 pieces of bun or bread on top and in the bottom. You have a piece of cheese and you have a meat. And basically the bun or the bread is the vaginal mucosa on one side, or the rectal mucosa and anal mucosa on the other side. The meat is the sphincter muscle, and the cheese is the perineal muscle. Now, why this is important: episiotomy, which is basically a full thickness tear, has a 3-fold increase in developing incontinence. We do know that patients who tear have a greater risk of a fecal incontinence compared to those who do not sustain a tear, 23 versus 13% in one study. And we do know that the highest risk is associated with 3rd or 4th degree tear. We also do know that a large amount of or large number of patients who undergo a repair of a 3rd degree continue to have a persistent defect when studied by ultrasound. In one study, up to 79% of patients who had a repair at the time of the tear and the time of the childbirth continue to have a persistent defect on ultrasound. Now, we do know that even patients who have a normal delivery without any apparent external tear, 36% of these patients, if you were to do either an MRI or an ultrasound of the anorectal area, you will find defects. So nearly 1/3 of patients with normal delivery, and only 4% of these would be symptomatic. However, when you look at patients who have undergone a traumatic delivery, either by forceps or vacuum extraction, 81% will have a defect and 38% of these would be symptomatic. So clearly, the deeper the tear or the more traumatic the tear, the higher the risk of a persistent defect and the risk of developing symptom of incontinence. It's important to note that systemic disease can lead to fecal incontinence. The leading cause not related to obstetrical trauma is neurologic disease. These could involve the brain, the spinal cord, the disorders such as multiple sclerosis, collagen vascular disorders such as scleroderma, diabetes and its associated neuropathy can lead to fecal incontinence. And finally, patients who have a significant degree of dementia can develop fecal incontinence. Pelvic denervation, specifically of the pudendal nerve leading to a neuropathy, can lead to fecal incontinence. This could be related to traumatic nerve compression, could be related to radiation-related injury or stretch injury or aging. Congenital causes are typically rare, but we do see, even as adult colorectal surgeons, some patients who've been operated at infancy for either imperforate anus, spina bifida, or a myelomeningocele of the spine. And these patients can sometimes get by during childhood, but as they get older, the incontinence become more severe for them and they present for evaluation and treatment. Now, the evaluation has basically 4 components. The history is very important, the physical examination. We try to determine the severity of the incontinence by using an incontinence score, a validated score. and we perform physiologic testing to try to better understand the problem of the patient. It's important when taking the history to distinguish between true incontinence and pseudo-incontinence. Pseudo-incontinence meaning they are factors not related to the anus leading to the incontinence. For instance, patient with inflammatory bowel disease or prior radiotherapy to the pelvis may have a non-compliant rectum that lead to overflow and the sense of urgency. Irritable bowel syndrome patient may have a normal pelvic floor but yet may have difficulty with incontinence. Elderly patient or the very young presenting with fecal impaction can have overflow incontinence. Some patient using psychotropic psychiatric drugs, patient who take laxative, or patient with diarrheal infectious causes may witness the urgency or overflow, but that's pseudo-incontinence because the sphincter mechanism usually is normal. Other causes of pseudo-incontinence, perineal soiling, known otherwise, poor anal hygiene, the presence of an anal fistula and drainage from the fistula, the presence of prolapsing hemorrhoid or a mucosal ectropion, some dermatologic condition leading to perianal dermatitis can present as pseudo-incontinence, and finally, anorectal neoplasm, especially those in the distal rectum, may present with some degree of fecal incontinence. When questioning the patient, it's very important to distinguish whether the patient has passive urge incontinence or a mix of the two. Passive incontinence is loss of stool without awareness. Often these patients will go to the bathroom to urinate and they will find stool or smearing on the underwear. And usually these patients have an internal sphincter pathology because that's the muscle that contributes to passive continence. Urge incontinence, on the other hand, is the loss of stool despite an attempt to inhibit defecation. These patients do sense that they need to go to the restroom, but they cannot make it in time. This typically points to an external sphincter pathology. Another form of incontinence is post-defecation. These patients typically can hold and defer a bowel movement. They can empty their bowel, but later on will discover the passive seepage of stool in the underwear that's usually related to either perianal disease, anal disease such as hemorrhoid, or incomplete emptying from causes like rectocele. There has been many validated instruments to measure fecal incontinence. The one I use in my practice is called the Cleveland Clinic, Florida Fecal Incontinence Score. It's a score that goes from 0 being no incontinence to 20 being most severe incontinence. Usually 0 to 8 is mild fecal incontinence, 8 to 14 is moderate fecal incontinence, and 14 to 20 is severe. And typically we quantify the type of incontinence, whether the patient is incontinent to solid, liquid, gas, does the patient wear a pad to protect themselves, and does it impact negatively their lifestyle. And we score depending on the frequency of the incontinence. If the patient never has a symptom, it's a 0. If they rarely have it, less than once a month, they get a score of 1. If it's daily, they get a score of 4. If it's weekly, a score of 3. And if it's monthly, a score of 2. We quantify for each one of these categories and we add up for a total score. The physical examination is a paramount importance. Visually, it's important to inspect the perineum and the anal area for any sign of scarring, prior intervention, dermatitis, or a patchal anus, which can be present in a vast majority of patients with rectal prolapse. Sensory examination, I do a very simple test. I typically take a sharp object such as the tip of a metal paper clip, and I poke the patient around the perianal skin and ask them if they can sense a sharp or a dull sensation. You could take the paper clip, the other side of the paper clip where it's not sharp, and you can touch the patient, and typically they should sense a dull sensation. And that's the sensory examination that I do to get an idea whether the patient has sensation in the area or not. Digital examination is to assess for the resting tone, the voluntary squeeze, and more importantly, when I ask the patient to squeeze, I watch to see if they're squeezing with the buttock musculature or the anus. Typically, patients who try to compensate for a weak anus, will squeeze with the buttock. I also assess for the perineal bulk, especially in women. I will take a feel of the rectovaginal septum. I also will assess for the presence or absence of rectovaginal fistula, presence of rectocele, and finally, an anterior compartment assessment to look for cystocele, a bladder that has dropped, or a vaginal prolapse. As we do know that some patient, in most studies, up to a third of the patient will also have an anterior compartment pathology as well. Anorectal manometry is very important to quantify the sphincter muscle complex level of squeeze. In my practice, I use high-resolution anorectal manometry. It allows me to gather data for both resting as well as squeeze pressure. I can measure the length of the anal canal and the high-pressure zone. I can assess for rectal sensation, the capacity of the rectum, and the compliance. And finally, I can test for the rectoanal inhibitory reflex, its presence or absence. This is a setup for anorectal manometry. It involves a perfusion catheter, often with 8-channel, with a mounted balloon at the tip. There's a computer station to obtain the recording. This is a tracing from a high-resolution manometry, basically reporting the resting pressure and the length of the anal canal. You could see both the number on the right, and there are a certain range for normal or abnormal result. And also you could look by the color. The color, basically, the yellow is a low pressure, the red is a very strong pressure. And so we get both a visual recording as well as a numerical recording. Anal EMG is very important, typically performed by either a neurologist or a colorectal surgeon. It measures the motor unit potential of the sphincter and identify areas of injury. In essence, it will map the anal sphincter muscle and tell you whether there are some areas of fibrosis and scarring. It can be done using two techniques. One is a needle technique, where you use a needle and you stimulate various areas of the anal sphincter circumferentially, or there's the plug technique, where you put a plug inside the anus and you record simultaneously data from a 360-degree circle. And this is basically a station for anal EMG. It has a computer laptop station and has a small device with attached cords, and the cords go to either the needle or the plug for the EMG recording. Now, measuring the pudendal nerve terminal motor latency is also very important. As I alluded to before, neurologic disease can lead to fecal incontinence. Typically, we define the pudendal nerve terminal motor latency from the time we stimulate the pudendal nerve at the ischial spine to the time we get a muscle response within the anal sphincter muscle. And this is one disposable device that you can use. It's called the SameMark probe. It basically has a finger-mounted electrode, one for the stimulating electrode right at the tip of the finger, and that usually is placed against the ischial tuberosity or the ischial spine, and then a receiving electrode where you can measure the speed with which the signal travels down to the anal sphincter muscle. You insert the finger inside the rectum and you palpate the anticipated area of the pudendal nerve, and then you stimulate the nerve and you record the motor latency. Now, imaging is very important, and we have two forms of imaging, endoanal ultrasound as well as MRI. I will discuss both. When I started my practice, two-dimensional ultrasound was the most commonly used modality. Now we see more and more three-dimensional ultrasound as well as MRI being used to interrogate the sphincter muscle and identify any areas of abnormalities. And going again over the anatomy, this is the anatomy of the anorectal area as defined by Dr. Shafiq from Egypt many years ago. The top of the sphincter complex is the puborectalis muscle, which starts at the pubic symphysis and wraps around the anorectal junction. Then you do have the external sphincter muscle in its three components, the deep, superficial, and subcutaneous. The middle aspect of the sphincter muscle wraps posteriorly as the anococcygeal ligament and attaches to the tip of the coccyx. And this anatomy is very important when you look at imaging. Now, here's a cartoon on the left with a coronal view of the anorectal area. The blue line is at the level of the puborectalis muscle. The red line is at the level of the mid-anal canal, and the yellow line is at the level of the low sphincter complex, right as the internal sphincter muscle tapers off, and we're only left with an external sphincter. On the right, you have three panels that basically illustrate this anatomical finding. The top slide shows the U shape of the puborectalis muscle as it wraps around the anal canal. The middle panel here show you the external sphincter muscle, which is the white circle going all around the anus, and the black is the internal sphincter muscle. And as you get further down in the distal anal canal, you have a very thin internal sphincter muscle, and you still have the presence of the external sphincter muscle. And this is a beautiful illustration of a normal patient here at the level of the mid-anal canal. You see an intact external sphincter muscle, which is a round white circle. It's thick and complete. And you see an internal sphincter muscle here, which is grayish to black in color, and it also looks like a full circle. Now, compare that to a patient who had a hemorrhoidectomy, a female who presented with passive fecal incontinence. And as you see here, the external sphincter look intact, but the internal sphincter, instead of being a complete O, looks like an inverted C with a defect of approximately 90 degrees in this area. This is a 58-year-old male who presented with fecal incontinence after a fistulotomy. And as you perform the ultrasound, you see a break both in the internal as well as the external sphincter muscle in the right posterior quadrant. There's a defect here of about 58 degrees. And there's another case illustration at the level of mid-anal canal of a patient who underwent fistulotomy, has a very narrow defect that you see here that is through and through, this black shadow. Now, MRI is now more commonly used to look at the sphincter muscle. This particular patient, we're looking at the most upper level of the anorectal area. We're looking at the puborectalis. Typically, the puborectalis muscle at that location is 2 to 3 times thicker than what you see here in this patient who has atrophy of the puborectalis muscle related to prior pelvic trauma. And this patient has fecal incontinence following a lateral internal sphincterotomy for a chronic anal fissure. As you see here, the surgeon mistakenly cut both the internal sphincter muscle. This is the black signal you see here, where the internal sphincter muscle is missing. But also, if you compare the right side of the slide, which is the left side of the patient, to the right side, you see extreme thinning of the external sphincter muscle, denoting as well an injury to the external sphincter muscle. Now, as the audience know, typically when we perform a lateral internal sphincterotomy, it's confined to the internal sphincter muscle only, but in this case, the surgeon cut both mistakenly. Now, the last few slides on medical management. Some patient, we work with dietary modification. We maintain a diary and ask the patient to record every day what they're eating and how many bowel movement they're having and whether they're experiencing any fecal incontinence or not. I typically tell the patient to gather data for at least 1 to 2 months and circle in red the bad days, the days when they had more incontinence, and see whether they can identify any particular food that's driving the incontinence. Some patients do report that they can clearly identify certain things that lead to more incontinence and certain food items that provide them better control. It's also important to know that a certain supplement, such as sorbitol, commonly found in sugarless gum, can contribute to stimulating the colon and can lead to fecal incontinence. So we also assess not only for food, but also is the patient using any type of candy or gum, or taking any medication. Now, in terms of medication we use for fecal incontinence, Imodium, antidiarrheal pill, can often be helpful. Patients who have chronic diarrhea can also benefit from a bile salt binder. These are to absorb the bile from the terminal ileum. Some patients will have improvement with fiber, and some patients we put on tricyclic antidepressant medication such as Elavil, and that can provide some improvement with the fecal incontinence. After an assessment of the diet and dietary modification, the use of medication, if the patient remains incontinent, we refer the patient for biofeedback and pelvic floor rehab. The most simple form of it is Kegel exercises, and I'll show you some biofeedback training done with the devices. And there are some devices such as anal plug and rectal irrigation that can be used to provide some additional support to the patient. This is a biofeedback unit that basically has a sensor probe, has a catheter with an insufflation syringe, and has a monitor on which you can record the amount of pressure that the patients generate, and you can give immediate feedback to the patient as they try to recruit the pelvic floor musculature and the anal sphincter to improve their continence. This is typically done in a physical therapy unit. Some patients are arranged to have a home unit to continue their therapy at home and only visit the physical therapist once a week. I often recommend a minimum of 3 months of physical therapy, and surprisingly, a lot of patients do get benefit from the biofeedback retraining. Anal plugs have been available on the market, and basically this is to mechanically block the anal opening to minimize the fecal incontinence. The one that is on the right is a new device that looks like a tampon. It has a string externally that remains to the outside, so you put the tampon to plug the anorectal area. When the patient needs to defecate, they pull the tampon out, they defecate, and then they place a clean one. Rectal irrigation can be very helpful for patients, specifically those who have post-defecation fecal incontinence. If they have any residual stool, by flushing it immediately after a bowel movement, they can completely clean and empty the colon. But also some patients do routine rectal irrigation every morning to stimulate the colon to empty while they're on the toilet. The simplest form of rectal irrigation is basically the use of an enema, warm water enema. The patient who need more volume can use a rectal irrigation set denoted here. So in conclusion, ladies and gentlemen, incontinence has a worldwide prevalence and has a negative impact on the quality of life for the patient. It can lead to isolation, problems in relationship, and loss of employment. It's also the most common cause of nursing home admission in the United States in elderly patients. Treating the patient requires proper evaluation with a good history taken and a good physical examination, supplemented by physiologic testing in terms of ultrasound, nerve studies, manometry, and anal EMG. The medical management usually is a first line of treatment and can be beneficial in many patients, a combination of dietary restriction, the use of some medication, and physical therapy. However, for those who do not respond to that initial first line of treatment, there are numerous surgical interventions for refractory cases, which were not discussed in this talk and hopefully will be covered under some other format at your conference. And this is my contact information in Dubai. Should you seek any additional information, please feel free to reach out to me either by email or to my website. The picture here shown in the middle is the Museum of the Future, which was open in Dubai. It's a beautiful museum, voted one of the most beautiful structures in the world. I do hope you visit Dubai, you visit this museum and many of the beautiful venues that the city has to offer. Again, thank you very much for your attention and for the kind invitation to be a speaker at your conference.